Welcome to ACC 2024. My name is Debbie Teodorescu. I'm a cardiology fellow at Cedars-Sinai, and I'm joining Dr. Gregory Marcus here today from UCSF to talk about the TRAVERSE trial. Dr. Marcus, I know that before you had conducted the very impactful TRAVERSE LA trial. Is this any way, shape, or form related to that?
So it was a little bit of having fun with the acronym, which is always important. Where TRAVERSE LA, the one commonality is they both had to do with a randomized assessment of different ways to conduct transeptal puncture, essentially. TRAVERSE LA was comparing a mechanical needle versus a RF needle. This one is based on our initial observations that surprisingly up to 60% of people undergoing a left ventricular catheter ablation manifest a new brain emboli, which is much higher than the rates that have been observed with atrial fibrillation ablation. And so we wondered maybe that has to do with the retrograde aortic approach that's commonly taken. And so this most recent TRAVERSE study, which was funded by PCORI, the Patient-Centered Outcomes Research Institute, which is a federally funded not-for-profit entity, was designed to essentially test the hypothesis that if we conducted a VT ablation or PVC ablation in the left ventricle via a transeptal puncture, that would substantially reduce the risk of a new brain infarct compared to the more conventional retrograde aortic approach.
So Dr. Marcus, are you willing to share a little bit about what are the key results that you want people to be taken away?
Yes, happy to. So first, our main outcome was by intention to treat. We did have some crossovers as we expected. Importantly, given our hypothesis that it would be the retrograde aortic that would lead to more brain emboli, we counted a crossover if someone was in the transeptal arm and yet ended up also getting or instead getting the retrograde aortic. So first I'll talk about intention to treat. We found that 25% of those undergoing a transeptal puncture had a new brain infarct compared to 48% of those in the retrograde aortic arm. Now, in the as treated, this was amplified. So if we looked at only those who got just a transeptal, 23% of them had an infarct. And of all the people that had any sort of retrograde aortic, 49%. So essentially half of them had a new brain infarct. And both of those were highly statistically significant. So essentially about double the risk and about 20% absolute risk increase in the retrograde aortic arm. Now, we also did look at, and I should say, it's important to mention the context being no difference in efficacy of these procedures, nor any meaningful difference in overall clinically evident complications. There were also more brain emboli. So even independent of whether it was there or not, those in the retrograde aortic arm had a greater number of new brain emboli. Finally, we looked at neurocognitive assessments at 6 months. One of our limitations is there was substantial dropout, unfortunately. So we didn't have great follow-up, but there was a suggestion that the neurocognitive improvement that was generally seen was not enjoyed as much by the retrograde aortic arm.
I see. And to help people put this into context, what wound up being the demographics of the recruited patients?
Yeah, they were fairly heterogeneous. The average age was around 60. About 15% were of race or ethnicities other than non-Hispanic white. So there were more non-Hispanic whites and men than any other group. The age range was around 50 to around mid-70s.
And so are there particular takeaways that you want everybody to emerge with? Of course, not everyone will be conducting VT ablations, but lots and lots of cardiologists either refer people to procedures or perform other procedures that utilize retrograde aortic access, of course, even the common left heart cath. So what do you want people to take away from this?
Yeah, so based on our findings, a retrograde aortic approach substantially increases the risk of a new brain infarct compared to a transeptal approach. So this demonstrates that whenever we're accessing the left ventricle, probably the coronary arteries, that itself is unfortunately probably causing some damage, potentially to the brain, but also this suggests there may be emboli that are being sent off and causing other damage to organs. Now, there's a trade-off there with the benefit of the underlying procedure. So when there's an option, it's looking like the transeptal approach is the preferred one. The question will be, could you use a transeptal approach to get to the coronary arteries or other places that are currently easier to reach, such as a PVC or VT ablation in the left ventricle?
That's an intriguing point. I remember back in the early days of the partner trial when we were looking at systemic emboli. I mean, those are massive sheaths, of course. So looking at a minimum of 6.5+% of embolic risk, of just clinically detectable embolic risk. You're not using those massive sheaths, right? 7 French maybe or smaller?
Yeah, 8 to 9 French, for these transeptal or retrograde aortic kind of ablation catheters and ablation catheter related sheaths. And it is true, it's important to emphasize that these are largely asymptomatic now, based on MRI. We had some suggestion that there was a greater likelihood of neurocognitive decline in the retrograde aortic arm. And it may be that even though the adverse consequences are subtle, that they could still be clinically relevant as far as the daily life of our patients.
Indeed, it seems like it could be tremendously impactful for folks who refer to EP procedures, interventional procedures, structural procedures, all of it. So,
indeed, agreed.
Yeah. And then what had inspired you? Was it just the results of this, the 60% you were saying, or what was it that had personally inspired you when you were designing the study and thinking about the arm-to-arm comparison?
Yeah, so we were puzzled why such a high rate of new emboli with left ventricular ablation that was so much higher than what had been observed in many studies of atrial fibrillation ablation. And because VT and PVC ablations can be done by either a transeptal or retrograde aortic, some people may have their own biases and favor one or the other. We thought this was a reasonable trial to do. And recognize that the randomized design would help us really be able to confidently infer causal relationships.
Do you feel like you've been able to answer your own question from the results?
I think we have. I mean, they're answering any useful question, it also opens up new questions. So there does seem to be this baseline rate of emboli. So even in the transeptal arm of around 20%, maybe a little bit more than 20%. And so there's a question, how do we prevent that? And we did look at other predictors, and it looks like the amount of power that we deliver, meaning the watts delivered with our radiofrequency energy was important. That then brings up with the recent introduction of pulsed field energy ablation, which is now taking over for AFib. Is that going to have the same risk? We also found that older age was a risk factor, and there are probably patient characteristics that might still be important.
Do you feel that, even with a safer approach, you're looking at 20%, does it make sense to think about preemptively doing cerebral protection, things like that?
Potentially, those could be considered. The problem with the cerebral protection devices is they then introduce yet more intervention, maybe higher risk of complications. So I think we still need to better understand what the true long-term clinical consequences of these emboli are, because they may not be outweighed with a protection device.
To watch more videos like this, please check out youtube.com FITsOnTheGo and follow us on X at FITsOnTheGo. Thank you so much.
Thank you.